keep that up here just for a few more seconds. The last person I had signed in, the last three was Adam, Pam, and Tony. Adam, Pam, and Tony. All right, we'll move on. Once again, special needs or special healthcare needs is going to be the topic for the month of September. Um, it is good for 2 hours. The objectives will be the same as the first hour. We'll talk about different special needs patients, the role of the caregiver, which we discussed earlier, and the overall assessment of the patient. All right, so for this case study here, you've got a 5-month-old with a seizure, or she's having a seizure. You arrive on scene at the residence and you're met by a male. He's stating that his baby is having a seizure. So he's going to escort you into the residence, and you've got a 5-month-old that's lying on her left side and appears to be sleeping. Um, there's a female with the infant that tells you that the baby seized about 4 to 5 minutes and that she gave her a dose of this and she stopped seizing shortly after. What is this? Very common, very commonly seen. Marshall County said a sedative. How do you find out information about this? What's going to be some of the side effects? Kadoka said Valium. Okay. What's some of the side effects? And how do you find out, or how are you going to find out information or what you need to know? McIntosh said slower breathing rate. Okay. Awesome. 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 Marshall said history of seizures. McIntosh says, there you go. Med app on the phone. Burke said, ask the caregiver if you're not sure. Yes. Kadoka said seizure disorder. Yeah, all of the above. Guess what? Man, if I went on a call and I didn't know what it was, hey, that's the first thing I'm going to do. Ask whomever, the parent. If it's the patients, I'm going to ask and find out. So find out. My brother used to always say a closed mouth won't get fed. So you've got to ask these questions. Once again, not only are you a provider, but situations like this, you're a detective. You may have to pull your phone out and Google it, or just like McIntosh says, that Med app. Because guess what? This is popular. It's out there. It's out there. And if you don't know the side effects, this can be somewhat disturbing. So make sure that you ask questions. Make sure that you try to find out as much as you can about these medications that was given prior to your arrival. All right. So this is your general impression. 5-month-old female lying on her left side, and she appears to be sleeping. She appears to be sleeping. 5 months old. All right. So your general impression, she's lying on her left side, appears to be sleeping. She responds to deep, painful stimuli. Airways patent. She is breathing, slow, irregular rate. Breath sounds are clear bilaterally. You've got a good brachial pulse. Her skin's warm, dry, pale, bluish color, no external bleeding. How would you categorize this patient? Okay, let's see. Everybody said sick. Let's see. We've got Marshall County said sick. McIntosh, Burke, Tony, Adam, Kadoka, all sick. Okay. Now, what makes this patient sick? Kadoka said postictal. McIntosh says breathing. Marshall said the cyanosis. Adam said the altered mental status. Tony said level of consciousness and breathing. Burke said that slow, irregular breathing. Now, that breathing and that altered mental status, could that be a side effect of the Valium that she had taken? Could it be a side effect? Okay, Tony, Kadoka, McIntosh says yes. Burke said yes. Marshall said some, but some postictal. Okay, all right. Yeah, it could definitely be a side effect, but I mean, this is concerning. 5 months old, deep painful stimuli. Guess what? I'm going to place her in that sick category. This is what concerns me, too. This is what really concerns me. And this right here, that pale bluish color, that's concerning to me. So yes, I'm going to categorize her. Now, any emergent treatment that you could provide right now? Okay, McIntosh says BVM O2. Burke said O2 if needed. Okay, all right. Let me help you out a little bit here. I'm gonna give you some vital signs. You got a heart rate of 116. She's satin at 92%. She's breathing 20 breaths per minute with an end tidal of 40. Blood pressure 84/53 with a MAP of 63. Talk to me. Now, I'm going to ask you another question. What kind of insurance policy do you have on your truck for situations like this? What kind of insurance policy? State Farm, Progressive? What kind of insurance policy do you have on your truck to help you with this? 5-month old. Kadoka said for the driver or the passenger. What kind of insurance policy do you have on your truck to help you with this call? It's not really, I just call it an insurance policy, Kadoka. 5-month old. Mary said Narcan. Okay, so hey, that's good thinking, Mary. But being that that medication is um there you go, Macintosh. There you go. Don't forget about your Broslow tape. Don't forget about your Broslow tape and your Broslow bag. Do not forget about that when it comes to peds. Any pediatric. Guess what? Stretch it out. You're gonna have all your vital signs for that age range. Gonna have, respiratory rate, heart rate, what the blood pressure should be. What's not good about this? Okay. Marshall said the pulse is too low. McIntosh says BPO2 sats too low. Think about a 5-month-old. What should that breathing rate be? Okay, Marshall said 20 to 40. Once again, you pull that Braslow, stretch it out. Guess what? You counted 20 breaths per minute. Ooh, let's get that bag valve mass in that O2 out. Get an NPA if we got an NPA big enough. And let's start ventilating that patient because that rate should be higher than 20 breaths per minute. They should be up to 30 to 40 breaths per minute with this age group, a 5-month-old. So you start bagging your patient every 2 to 3 seconds. You're ventilating your patient. You got good rise and fall. You're not over ventilating by emptying the entire bag in their chest. You're just squeezing enough to see the chest rise, allowing it to fall. One breath every 2 to 3 seconds. Just enough to see the chest rise and fall. So you got your airway managed at this point. Anything else concerning here? You've got your airway managed. Okay, Kadoka said retaining CO2. Okay, all right. Okay. What about that map? Is that map, does that concern you any? That blood pressure in that map? Okay, Kadoka said the blood pressure is close together. Marshall said, "What should a map for a child that young be?" Okay, that's a great question. So the map for a child is still going to be the same thing. From 70 to 110 is going to be that normal range. So we're dealing with a low map which could be very concerning when it comes to that 5-month-old. That's going to be somewhat concerning there. All right. What other diagnostic tools would you use? Okay, Dawn. Dawn said blood glucose. Tony said glucose, 12 lead cardiac monitoring. I mean, Marshall said, does it come up with ventilation? No. McIntosh says blood glucose and temp. All right, so you obtain a blood glucose. You get a glucose of 93. All right, Dawn, keep that thought. Dawn said, look for signs of dehydration. You get a temperature, and she's normal thermic. All right, you start interviewing mom and dad. She had a seizure. Now you've got altered mental status. No allergies. She takes a multivitamin. They gave her Diastat. You know, every time she have a seizure, they give her the Valium, and that stopped the seizure. She also takes Lasix. She's got a history of hydrocephalus with a VP shunt, and she also has a history of seizures. Last oral intake was 3 hours ago. She's been real irritable, lethargic for the past 2 hours. This was a sudden onset, and she got really fussy over the past 2 hours and hasn't been eating. Okay, Marshall, keep that thought. I see you. Keep that thought. What are you thinking? Any concerns? Okay, Tony asks, is she compliant with the Lasix? Yes, she is compliant with all of her medication. She is compliant. All right, so let's move further into your assessment. Due to her altered mental status, we're going to perform a head to toe assessment on this patient. We're going to look for clues. We've got to look for clues. You check her fontanelle. You notice that it's bulging. Her pupils, 5 millimeters bilaterally. She does have swelling and redness along her shunt track. Her face is symmetrical, pale bluish skin, trachea is midline, no jugular vein distension. Breath sounds are clear bilaterally, abdomen soft. She is positive for incontinence, urinary incontinence. Lower extremities intact, upper extremities are intact. You log roller, and her posterior area is intact as well. What you find? What are you thinking? What are we thinking? Marshall said lethargy and infection along the shunt. Okay, Macintosh. Okay, I like that. I like that. Marshall said bulging front nail. Okay. Burke said infection, shunts plug, call for flight. Okay. All right. What? Okay. Let's start at the top. What is that telling you right there? Okay, Tony, keep that thought. What is this telling you right here? When you assess that front nail and notice that it's bulging, Marshall County said not draining. You got a bulging front nail on an infant. What is that telling you? Okay, Tony said swelling. Marshall County said high pressure. Now, what if it was sunken? Kadoka said pressure. Yes, yes. That bulging front nail. What if it was sunken? Marshall Burke said dehydration. Tony said dehydration. McIntosh says dehydration. Yes, indeed. Yes, indeed. Once again, we have to perform that assessment. Anybody can do an assessment, but everybody can't do a thorough patient assessment. And as a provider, this is what we have to perform, are those thorough patient assessments. So looking at that front nail, feeling around for that front nail to feel to see if it's sunken or it's bulging. If it's bulging, hey, we got too much pressure up here. We've got too much pressure. If it's sunken, hey, there's a possibility that we could be dealing with dehydration. All right. So, great answers. Great answers. Great answers. Awesome. 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 What about our pupils? Any concerns there? So we're looking at, I don't know if you all can see that, 5 millimeters. And this is, if you can see that, about 5 millimeters. Okay. Let's say they say everybody said dilated. Okay. All right. So they're a little large. They are a little large at 5 millimeters. Okay. All right. All right. So we're looking at pressure. We are looking at pressure. All right. So we know the history. Hydrocephalus. Once again, special needs. Special needs. We've got too much CSF or cerebral spinal fluid on the brain. These patients build up absolutely too much cerebral spinal fluid on the brain. She also has what's called a VP shunt. A VP shunt. You have two different types of shunts. You have a VP shunt and you have what's called a VA shunt. With your VP shunt, she's got this tube, and this tube basically drains that fluid. Typically, that tube runs behind her ear down into her chest. And if you can see this picture in the background, down into the peritoneum or into the abdomen. And it drains and disperses that excess fluid into the abdomen. VP shunt, ventricular peritoneal shunt. One of the big problems here are complications. You got infections and they can develop peritonitis. Back in the day, one of the problems, and you don't see it a lot anymore, patients used to outgrow these shunts all the time. They don't outgrow them as much anymore. And you would see problems. So that's your VP shunt. When it comes down to your VA shunt, it runs behind the ear, the drain does, into the right atrium. So ventricular atrium. So your VA shunt and then your VP shunt is in the abdomen. VA is in that right atrium. Okay. All right. And same as with that, VA or VP, both of them, you got to deal with infections. They're at risk of infections, obstructions, which can lead to increased intracranial pressure and then inflammation of the abdominal lining or peritonitis. All right. So once again, we are dealing with a tube. And that mnemonic that we talked about earlier, basically any tube you come in contact with, it can be troubleshooted with dope. D stands for displaced, O obstructed, P peritonitis, and then E equipment. The E is equipment. Now back to the brain and the ventricles, the CSF. That cerebrospinal fluid is produced by the body. The overall goal of the cerebrospinal fluid is to add protection to the skull and the not the skull, but the brain and the spinal cord. So 24 hours a day, 7 days a week, is circulating throughout the body. It's produced in the ventricles and it circulates carrying nutrients and removing waste products. And it acts as a cushion. It acts as a cushion. Now, when this is what a normal ventricle starts or are supposed to look like. Once you have that buildup of fluid, they have so much fluid until it starts putting pressure on the brain. And once it starts putting pressure on the brain, this is where you start seeing those signs and symptoms. Now, when you come in contact with this particular patient, this special needs patient, um, it's just like you're dealing with a stroke, just like you're dealing with a head injury. They can be complaining of a headache. They can be complaining of vision problems. Their coordination may be off. They may be unsteady, or just having problems with their overall balance. Now, with your infants, paying attention to that fontanelle. If that fontanelle is still open, always pay attention to that fontanelle. You're going to start seeing the bulging of the fontanelle. Other complaints, just them being irritable because of all of that pain. I don't know if I mentioned, but like with your older children and your adults, they have a lot larger heads. Their foreheads are a lot larger, or the top of their head is a lot larger as well. So these are all characteristics of that increased intracranial pressure or that buildup of that cerebrospinal fluid. Now, some of your other common equipment that's going to be seen with some special needs patients, you've got your central lines or your indwelling central lines, and this can be used for either short-term or long-term IV therapy. It's used for IV administration for nutrition, and then different medications can be given as well. Some of the biggest things that you have to worry about here is going to be blockages. It can be accidentally pulled out as well, or it can break. If your patient suddenly starts complaining of difficulty breathing, they become tachypnic, complaining of, or you notice that their mental status starts to drop, One of the things that you could do, this little blue clip, it would be on all three of them. Close it, slide it, and close it, and have that patient lie on their left side in a Trendelenburg position with their legs up, and place them on high flow O2. And the reason is there could be a possibility that that person is having a air embolism. So sudden onset of shortness of breath, increased respiratory rate. They may complain of sudden onset of sharp chest pain as well, and you'll start seeing their mental status to start to drop as well. Uh, Once again, that mnemonic dope. If you have any problems, you can troubleshoot it. Once again, the D stands for displaced, dislodged, or damaged. The O stands for obstructed. The P stands for pulmonary embolism, and the E stands for equipment failure. We've got your G tubes. We talked about your G tubes earlier. This is going to be a feeding tube that's basically surgically placed. You also have what's called J tubes as well. Your different complications here, you can have bleeding around the site. This site can become irritated or infected. The tube can actually start leaking, or it can get plugged up, and it can be accidentally pulled out as well. We also talked about the Foley cath, which is used to drain urine from the bladder. Once again, we always want to pay attention to the amount, the color, look for blood, pay attention to the tubing as well. Your complications here is going to be infections, and there's a possibility of trauma if it's accidentally or purposely pulled out. This is just your leg cath here, a different type of Foley cath that you may see as well. Dialysis, which is common. You may see this with some of these special needs patients. These catheters here can be somewhat of a nuisance there. You've got your dialysis unit that basically filters or cleans the blood. Your complications with these catheters are going to be infection. We always want to try to take a sterile technique when we're handling these catheters as well. You can have bleeding from the line also, and they can become dislodged. Same as with the central cath. If that patient respiratory rate suddenly increase, or they become short of breath, or having chest pain or mental status start to drop, start thinking about the possibility of a pulmonary embolism. We want to clamp, and these are going to be your clamps. You see the red clamps there. You can clamp by pushing, clamp out both of them. Place the patient on the left side, place them on O2 with the head lower than the feet, basically that Trendelenburg position, and get them to the hospital as soon as possible. You've got peritoneal dialysis, which is another type of dialysis. You see a lot of patients, they're actually doing this at home. Patients can do it themselves, or then you have home health nurses that come in that do it as well. Being in the stomach, in the peritoneal, these patients can develop infections like staph, or they develop peritonitis as well. Always pay attention for any discoloration, whether it's redness or any swelling or tenderness around that entry. All right. So you move your patient to your pediatric transport device, begin transporting lights and sirens to the hospital. En route, you notice that she has a seizure type activity. These are your repeat vital signs. You got a heart rate of 60, O2 sat of 94, you got an end tidal of 55, you're still ventilating your patient, and your blood pressure is 136/94 with the map of 108. What's happening? She telling you a story once again, and she never had to open her mouth. Marshall says she's crashing. Yes, she is crashing. What is happening? Keep that thought, McIntosh. I saw that earlier. Okay, Marshall County said pressure. Okay, okay. Yes, indeed. Anyone else want to chime in? She's talking to you, 5 months old. She's telling you a story. Okay, Marshall, I see you. Yes. She's telling you a story. All of these vital signs, the bradycardia, slow irregular respiratory rate that you're managing, the hypertension. What is that 108, that map? What is that telling you? Okay, Burke said increase. Yeah, yes, yes, indeed. Increased pressure. Listen to what I'm saying. This, start using this. Start calling it in on your radio reports. Start calling it in. This is one vital sign that's going to help you when it comes to perfusion and pressure. If you call in, I got a 5 month old with a blood pressure of 136 over 94 and a mean arterial pressure of 108. Guess what? That sense of urgency, medic, whatever you are, can you repeat what you said that mean arterial pressure was? Mean arterial pressure of 108. 10-4, we'll see you on arrival. Guess what? That's going to get somebody's attention right there. That's going to get somebody's attention right there. All right, so just the opposite of shock. Her body is compensating for that increased pressure. That increased pressure, or AKA herniation. We have to remember when it comes to the vault or the skull, there's little to no room to do anything or for anything other than the amount of cerebrospinal fluid that's supposed to be in there and the brain. Once you start putting pressure on the ventricles and the ventricles start to expand, pushing the brain against the skull or the cranium itself, it has nowhere else to go than through the base of the brain or the magnum foramen, which is that hole in the base of the skull. Has nowhere to go. And the body starts trying to take care of itself. Blood pressure starts to increase. Pulse rate drops down. Respiratory rate becomes slow and irregular. Once again, just opposite of shock. You may see seizure activity. You may see posturing, decorticate posturing, decerebrate posturing. With all of that pressure that's put on the cranial nerves, guess what? You're going to start seeing changes in the pupils. You're going to see pupillary changes. And all of this is from that buildup of cerebrospinal fluid. Basically, with this patient, all you're dealing with is basically a stroke patient, a head injury patient. Kind of the same concept. Kind of the same concept. The only difference is you're dealing with a shunt. We can't do anything about the shunt. We've got to provide good airway management with this patient and get them to the hospital ASAP. Good airway management and get them to the hospital ASAP. When it comes to airway management for these patients, we used to, any head injury patient, guess what? We used to hyperventilate them. Hyperventilate them. Now, with the research, evidence-based medicine, the hyperventilation is not recommended anymore because all we were doing was constricting the vessels. And with fully constricted vessels, you have less blood flow and you have less oxygen flow. The brain is very stingy. It has to have a constant flow of oxygen also a constant blood supply. And by constricting those vessels down, we were causing more harm than good. Now, the concept was cool because the vasoconstriction brought the swelling down, but they want these patients as neurologically intact as possible. So now instead of hyperventilating, it's called a mild controlled hyperventilation. End-tidal CO2 is going to be your best friend. Your normal range 35 to 45. But when you're performing that mild controlled hyperventilation, keep it between 30 and 35. 30 to 35. And you're performing that mild controlled ventilation. And this is only if there's signs and symptoms of herniation, the Cushing's response, the bradycardia, slow irregular respiratory rate, the hypertension, the blown pupil, the seizure activity, the posturing, all signs of herniation. If you do not have end-tidal CO2 or capnography, adults 20 breaths per minute, child 30 breaths per minute, and infants 35 breaths per minute. 35 breaths per minute. But this is your treatment, airway management. Once again, that's the cause which leads to herniation. And this is actually bleeding, but this is the only herniation picture that I could find that was, you know, actually I should take that out. All right, so you do another secondary survey. You notice that fontanelle is budging. You've got swelling and redness along the track, the shunt track. The pupils are dilated and sluggish. Your right pupil is 7 millimeters and the left is 1. Face symmetrical, trachea is midline, no jugular vein distension. Chest is unremarkable. You still notice the incontinence was noted. Upper and lower extremities were intact. So as the pressure rises, your patient starts to get worse. Your repeat pressure 164/96 with the map of 118. You're still ventilating the patient with the end-tidal of 30 and a heart rate of 70. So when it comes to these special needs patients, your assessment does not change. Your assessment is still going to be the same. Uh, Once we arrive on scene, go through your primary assessment. Make sure that we listen to the parents. Make sure that we listen to the caregivers because they're going to be have a plethora of knowledge when it comes to the patient, not only the patient, but the equipment as well. You're seeing more and more service animals out there. You're seeing more and more. You have your service animals. They aren't just used for guiding patients or guiding blind patients anymore. You've got service animals out there that can detect seizures that may be oncoming. They can detect when a person's blood glucose level is going to drop. They're trained to open doors. They're trained to carry items, and they're there for comfort as well. Typically, your service animals are considered dogs, and then you've got miniature horses, but they have to be under 34 inches. Under 34 inches. Um, Once again, I thought this was the coolest service animal I ever saw right here. That would be something to go in and this guy is there. Sensory kits, you've got your sensory kits. You're seeing more and more of this when it comes to your special needs patients, especially your patients that are suffering, that are on the autistic spectrum, that are on the autistic spectrum. What these sensory kits are used for, they're used to calm the patient with autism, especially if it's an emergent situation or a stressful situation. You've got the different contents. You can actually buy these sensory kits, but you got a lot of services. Basically, what they do is just make their own. You've got noise canceling headphones. You've got sunglasses. You've got your different tactile toys that's used, and you've got weighted blankets. But you are seeing this more and more, these sensory kits on ambulances or ambulance services, um, utilizing these more. All right, educational pearls to consider here. Key considerations: there will be communication barriers, language, sensory, physical, and cognitive barriers when we're dealing with these special needs patients. Your assessment findings: you may find prostheses, extremity prostheses, hearing aids, magnifiers, speaking valves, if patients have trachs, canes, wheelchairs, or motorized scooters. We just finished talking about service animals. Um, they are basically protected by the American Disabilities Act. We talked about the dogs. We talked about the miniature horses as well. They're not classified as pets, and by law, they are permitted to accompany the patient unless they are out of control or the handler
Why they leave
cannot
that thing hanging? Why
control
not
them.
just let it sit on the floor?
Uh, let's see. I got someone.
All right, I gotta pick the kid up.
All right. Or the animal isn't housebroken. It's illegal to request special ID or documentation when it comes to identifying the patient as I mean the service animal. Here, key documentation. If there are any language sensory barriers, or if you had to assist with any adjuncts or physical barriers, we want to make sure that this information is documented as well. When it comes to overall performance measures, we always want to make sure that we have that key data, which is going to be your chief complaint, past history, meds, allergies, any adjuncts that were used to overcome any communication barriers or barriers the patient may have had, and complete and accurate transfer of information once you arrive at the receiving facility. One of the most important things to remember when assessing and treating patients with special needs is that they are people first. Always perform thorough assessments as you would with any other patient, and use their knowledge and their family's knowledge about their condition to help you make good treatment decisions for them. Any questions? If there are no questions, I want to thank you for attending tonight's presentation. Once again, thank you, thank you, thank you for your interaction. You really make it fun. I love the competitiveness, especially on this night here. So thank you for basically interacting with me. If there's anything that I could do to assist you along the way, please do not hesitate to contact me. I will, if there are no questions, I will see you next month. Thank you, Marshall. Thank you, Tony. Thank you, Macintosh. Thank you. Thank you, Burke. Thank you, Kadoka. Thank you, Macintosh. Adam, thank you. Emily, thank you. Dawn, thank you. You all have a great evening, the rest of your evening.